Good afternoon, Sir Mike. So can you tell us a bit about yourself?
Good afternoon. Yes, certainly. I'm first and foremost a doctor. I come from a medical family. My father was a GP. My older sister is a community paediatrician, just retired. My younger brother is also a GP, but now leading a clinical commissioning group. So perhaps surprisingly, it took me till I'd been at university a year even to work out that I might want to be a doctor. But I've had very happy career as a doctor, 25 years working in general medicine and then in cancer medicine, then palliative medicine. And then in 1999, I moved to the Department of Health as the first national cancer director, really responsible for trying to bring about a drive and change in cancer services because we knew we were lagging behind in this country.
And what attracted you to the job of Chief Inspector of Hospitals?
I suppose the thing that attracted me most was the challenge. I believed that I could use some of the experience I've had in cancer in bringing a sort of whole system change, but do that on an even wider platform, that of hospitals, which matter enormously to the public. The NHS, as we all know, matters hugely to the public. Hospitals are perhaps the most obviously facing part of the health service, and we need to make sure that our hospitals are delivering high quality care. And to do that, we need to measure that, to inspect it, to come up with ratings, but that will then work with partners to drive improvement.
In this new system you're talking about, what is the role of the Chief Inspector?
The Chief Inspector's role is to oversee, to coordinate, to lead this movement for good inspection. And to say we need to learn from others about inspection, to learn what's been done in this country in different ways, learn from what CQC has done in the past, learn from the Keogh review, learn from what people do in other countries, and bring all that together and say how can we pool that to say this will represent good inspection. I'm absolutely convinced that we need to have large panels doing this, bringing together doctors, nurses, managers, alongside professional regulator staff, the CQC staff, who can really make sure that we do it robustly, that we produce the evidence. And what I'm hoping to do is to say, let's take the emergency pathway from the time a person comes to A&E, moves through A&E to the emergency assessment unit or the emergency medical unit, whatever it may be called, then onto a general ward, then maybe onto a ward for the frail elderly. Follow the patient through that pathway and see, is the care delivered at each step in that pathway really working? Because I think often it can be the handovers between different parts of a pathway that fail. So, for example, how well does a hospital look after patients who are deteriorating? And how well do they do that out of hours at a weekend? And do they have the systems in place for early warnings, for escalation, who's there? Do they have the right critical care outreach service, whatever it may be? And I think we can then look across a pathway. And of course, actually within that, the essential standards will still remain important. We still need to check that people are getting food and water. And so all of those things will remain important, but it'll be doing it in a different way and with more clinical involvement alongside professional inspectors.
Now, you've identified a list of 18 trusts as the first to be inspected in this new way. Why those 18?
Well, we thought long and hard about this, about where we should go first. One of the key things I want to do is to test out our new surveillance tool. As people will know, we're out to consultation on this at the moment, and we've set out all the metrics in Annex A of the consultation document, and I hope people are reading that and will comment on it. But we've got a very good start there. So we've got a number of indicators for each of the 5 domains of safety, effectiveness, caring, responsiveness, and being well led. And those metrics hopefully will allow us to identify trusts that are at higher risk or at lower risk. Now we need to test that, but we think we've got enough there. So we've chosen 6 trusts that are apparently high risk, 6 that are apparently low risk, and 6 that come in the range in between, and they cover just about everything in between. And this will really help us to know what the range of quality of care is in this country, and I think that therefore by Christmas, when we complete this wave, we will know much more about our surveillance tool, we will know much more about our inspection programme, and we'll know about the first 18 trusts. We will definitely be getting the views of the public. We are committed to having patient and public listening events for each of our comprehensive inspections. Whether those are on site at the hospital, whether they are off site in the local town hall, I don't think that matters. What we need to do is to give people an opportunity ahead of the programme, either to come to a listening event by advertising it in the local press, or to send us their comments in advance. We've got to gather that information together. That's an incredibly important part of the preparation phase. And if we get the preparation for these inspections right, we get all the views. So it's the views from patients and the public, but it's also the views from Health Watch, from NHS England, from CCGs, from Health and Wellbeing Boards, the lot. We'll want to bring all that in, because that will help us to know when we go in, what are we really looking for.
How are you going to use our power as a new role to make sure that services improve?
Well, I think partly it is by taking a comprehensive view of that trust, giving that trust a clear response where we can show how they are doing about safety, effectiveness, caring, etc. And then by working with our partner organisations. And I've already had conversations with NHS England, with Monitor, with the Trust Development Authority, and I think we're all in this together. We will do the inspection bit, we'll be independent about that, but in terms of taking the action, we're all in it together, and there's a will to make this work now as never before.
Will some of that involve a slight shift in our relationship with some of these partner organisations?
If we say a particular trust is not doing sufficiently well, and we report on it as either requiring improvement or being inadequate, whether that's for the whole trust or for an aspect of the trust's care, the expectation is that that will be picked up. And we will also be saying we expect this to be done within X months, whatever that may be. It will then be a mixture. If it is a problem at board level, then Monitor or the Trust Development Authority will need to take action. If it's at a more localised level, it may well be that the Trust will take that action. The Commissioners have a role here as well. Part of our job is that we will be showing to Commissioners how good or poor the care is that they are commissioning. They will be given an independent assessment of the care in their hospitals. That's something I think they should welcome.
Now, we've read this week yet again about some serious failings at a series of NHS trusts across the country. What's our role in making sure that doesn't happen again?
Our role is to be open. Our role is to say it as it is. And my belief is that if we do that and we work with our partners, we will start seeing improvement. And I think quite a lot of these improvements can be made quite quickly. They're not all about massive investment. They're not all about new buildings or whatever. Some of these things we've picked up problems during the Keogh review that can be, they can get on top of really quite quickly. So that'll be the test. Are we seeing improvements? And when we go back for our follow-ups, are we seeing that the action that we have recommended or the problems that we've spotted have been dealt with?
What are the things you would like people to say about CQC that would show that this role has really had an impact?
We trust them. We trust them to find out what is good and what is less good, and we trust them to work with their partners to make things better.
Mike, thanks for your time.
Thank you.
Okay.